Chapter 14, Depressive Disorders. So depressive disorders range from mild to severe and may result in significant pain and suffering that disrupts daily functioning and has a negative impact on physical health. Having a medical illness, especially one that is chronic, is a primary risk factor for depression. All of these disorders share symptoms of sadness, emptiness, irritability, somatic concerns, and impaired thinking. According to the National Institute of Mental Health from 2021, there are 21 million people in the U.S. with depression. And when we're dealing with depressed people, therapeutic communication is a great tool. Sometimes just sitting with a patient in the quiet is beneficial. Spending this time with the patient can offer safety if suicidal, but also can convey to the patient that they are worth the nurse's time and attention. So major depressive disorder. We will talk about major depressive disorder, but also others that fall under the umbrella of depression, and this includes disruptive mood dysregulation disorder, persistent depressive disorder, premenstrual dysphoric disorder, substance medication-induced depressive disorder, and depressive disorder due to another medical condition. So first, let's talk about disruptive mood dysregulation disorder. It replaces the diagnosis of bipolar disorder in children and adolescents, which were being misdiagnosed and treated with unhelpful medications. This is more common in males, and symptoms include constant and severe irritability and anger that are present before the age of 10. Temper tantrums out of proportion to the situation at least 3 times a week. And it must be present in at least 2 settings. So, example, at home and school or with peers. To manage this, there is no specific treatment, so it should be more problem-focused based on the patient's symptoms. Can include medications, cognitive behavioral therapy, parent training, and facial expression recognition training. Persistent depressive disorder was formerly called dysthymia, or it means bad mood. This is a persistent depressive disorder, and it's characterized by low-level depressive feelings through most of each day for a majority of days that persist for at least 2 years in adults and 1 year in children and adolescents. They must also have 2 or more symptoms, including decreased appetite or overeating, insomnia or hypersomnia, low energy, poor self-esteem, difficulty thinking, and hopelessness. Because the onset of persistent depressive disorder is usually in the teenage years, patients will frequently express that they have always felt this way, and that being depressed seems like normal functioning. It is not uncommon for people with this low-level depression to also have periods of full-blown major depressive episodes. Cognitive behavioral therapy has been very effective in treating this disorder, and antidepressant medications are also used. Premenstrual dysphoric disorders is different from PMS, as it is more severe mood changes that do affect daily functioning. Symptoms of PMDD usually begin the week before a woman's menstrual cycle starts and decreases or subsides once menstruation begins. Your clinical manifestations include mood swings, irritability, depression, anxiety, feeling overwhelmed, and difficulty concentrating. Now, treatment consists of regular exercise, complex carbs, and sufficient sleep, as well as medications including things like YAZ, and your SSRIs. Symptoms cease after menopause, although they may return with hormone replacement therapy. So some other depressive disorders include substance-induced depressive disorder, which is a condition caused by drugs or alcohol in which the person exhibits prominent mood disturbances after substance medication use or withdrawal that impairs their daily functioning. Once the substance is removed, depressive symptoms usually remit within a few days to several weeks. Depressive disorder associated with another medical condition. This is simply depression caused by another medical condition. And you can see some examples here of a CVA, Parkinson's, Huntington's, Alzheimer's, TBI, etc. Table 14.1 on page 242 gives examples of both of these type of disorders. Okay, let's begin talking about major depressive disorder, MDD. It is one of the most common psychiatric disorders. It is a condition that causes a persistently low or depressed mood and a loss of interest in activities that once brought joy. To be diagnosed, symptoms have to be present for at least 2 weeks with a change in your previous functioning. You can see your DSM-5 criteria on page 242. Within this, you also have seasonal affective disorder. There is a relationship between changing seasons and the onset of depressive symptoms. It usually occurs in the fall and the winter months, and it is more common in women between the ages of 18 to 30. Symptoms of the seasonal variety of depression are similar to what you would expect with hibernation. So you have hypersomnia, overeating, weight gain, and craving carbohydrates. Populations that lie farthest from the equator are the most affected, and treatment is similar to that of MDD, but they also use light therapy. And then depression and grieving, again, experience similar symptoms of MDD. We previously waited 2 months following a loss to diagnose MDD, but now found that this delays necessary treatment. These patients may cry, feel hopeless about the future, have disruptions in eating and sleeping, and lose pleasure in everyday activities. They may even experience a lack of interest in caring for themselves and neglect normal hygiene. They may also experience psychomotor agitation, so they pace aimlessly. And back to, they may experience a lack of interest in caring for themselves and neglect normal hygiene. So if you're taking care of one of these patients and you notice that they combed their hair today, make an effort to acknowledge it. You could say something like, I see you styled your hair today. I see you put on a pretty dress today, just to acknowledge that you recognize the effort they put in. So epidemiology of MDD, it is the leading cause of disability in the U.S. and actually worldwide. It is more common in females, and those between the ages of 18 and 25 years old are affected the most. You can see figures 14.1 and 14.2 that show the prevalence in adults and adolescents. So in children and adolescents, it was not previously diagnosed in children, but we now know that even infants can experience depressive symptoms. In older adults, it is, again, as we talked about in the previous module, a common occurrence, and it is not a normal result of aging. Comorbidities, it can be a combination of several disorders, but anxiety is the most commonly diagnosed disorder with depression. So risk factors. Genetically, any first-degree family member with MDD puts you at a risk. Biochemical, they have neurotransmitter abnormalities, especially serotonin and norepinephrine. Serotonin is an important regulator of sleep, appetite, and libido. Therefore, serotonin circuit dysfunction can result in sleep disturbances, decreased appetite, low sex drive, poor impulse control, as well as irritability. Norepinephrine modulates attention and behavior. It is stimulated by stressful situations, which may result in overuse and a deficiency of norepinephrine. A deficiency, which is an imbalance as compared with other neurotransmitters, or an impaired ability to use available norepinephrine, can result in apathy, reduced responsiveness, or slowed psychomotor activity. Stressful life events, especially loss, seems to be a significant factor in the development of depression. Hormonal. They have the same receptors and pathways in the mood area of the brain as neurotransmitters. So hyperactivity of the hypothalamic pituitary adrenal cortical axis can actually be a cause. People with depression also have increased urine cortisol levels and elevated corticotropin releasing hormone. Interestingly, hypothyroidism can actually cause symptoms, and I'm talking about this because of hormones, that mimic MDD. Weight changes, sleep disturbances, low energy, and altered thought processes, or change in thought processes. Inflammatory. Research has shown that those diagnosed with depression have increased inflammatory biomarkers, and support for this belief includes that about a third of people with major depression have elevated inflammatory biomarkers in the absence of any physical illness. Diathesis stress model we mentioned in previous module. This is understanding the interplay between genetics and biological factors. The physiological vulnerabilities, such as genetics and biological factors. So the physiological vulnerabilities, such as genetic predispositions, biochemical makeup, and personality structure are referred to as diathesis. The stress part of this model refers to the life events that impact individual vulnerabilities. This explains why two persons exposed to relatively similar events may respond differently. One person may demonstrate resilience and another may develop depression. Cognitive. Some researchers believe that thoughts and how one looks at the world plays a major role in the development of depression. Beck found, you'll see here, that people with depression process information in negative ways and tend to ignore their positive aspects of their lives. Now, box 14.1 on page 245. The primary risk factors for depression is very important. These are going to be female gender, your ACEs, stressful life events, so things like trauma, divorce, abuse. Neuroticism, that's a core personality trait characterized by emotional instability, irritability, anxiety, self-doubt, depression, and other negative feelings. There's other disorders such as substance use, anxiety, and personality disorders, and also chronic and disabling medical condition. So Jeff, 19, is brought to the hospital after a suicide attempt. His parents found him in his backyard wearing his favorite black jeans and his black t-shirt, but with one of his father's neckties. He had overdosed on some of his mother's pills, but his stomach was pumped in time. He has just been admitted to your floor for 24-hour suicide observation. During intake, Jeff doesn't speak much, but his parents are able to list the following symptoms they have observed: weight loss and appetite changes, insomnia, fatigue, worthlessness or guilt, loss of interest in his college classes, and even the online games he usually plays with friends, constant sadness. Jeff's parents have described his lack of interest in things he used to enjoy, like games with his friends and his classes, which he used to like. This may be best described by the term anhedonia. So your nursing process. Why do you think MDD is unrecognized or underdiagnosed? Less than half of those that experience symptoms of depression actually seek help, but early treatment is crucial for recovery. So there are screening tools. You have your Beck Depression Inventory, the Hamilton Depression Scale, Geriatric Depression Scale, and Patient Health Questionnaire 9. And you can use these for baseline data to determine changes. An example of this is on page 249. So assessment and suicidality. Look, there's that anhedonia, which is the inability to feel pleasure. Assessment of suicidality. Suicidal ideations are the most dangerous aspect of MDD and the most common reason for hospital admission. They can range in severity from mild to formulating a plan. Assess the patient's thoughts regarding a plan and the means to carry it out. Risk is increased if the patient feels hopeless, if they use substances, had a recent loss or separation, or had a history of past suicide attempts. Okay, self-assessment. Do not feel like a failure if the patient rejects advice or encouragement. Recognize unrealistic expectations you may be placing on yourself and or the patient. Now let's talk about areas that we need to assess. Appearance. This is going to be clothes, hair, hygiene. Their affect, which is their outward representation of your internal state, is considered to be objective. Your outward representation, that affect, could display feelings of hopelessness, and you could even visual or on your face display feelings of despair. Behavior. Anergia is a lack of normal energy. They may have slow movements, psychomotor agitation such as nail biting and leg bouncing, and appetite changes, as well as change in bowel habits, sleep disturbance, and decline in sexual interest. Mood is simply your overall emotional condition. Feelings and emotions. So these are related to mood, but more specific and easily fluctuates. Anhedonia, which we mentioned, is the most common. Now your affect. This is the patient's immediate outward expression of emotion and is objective, based on assessment by the nurse. Types commonly seen with depression include constricted, blunted, and flat. Their speech may be slowed, and their thought processes may also be slowed, or they may have a poverty of thought. Thought content and perceptions. Psychosis symptoms may be present in profound depression. Insight and judgment. They may have an inability to make clear decisions and solve problems, and they may have cognitive changes, which cause functional impairment and may linger after successful treatment. Now, there are age considerations in children and adolescents. MDD may be overlooked as it does not always present like it does in adults. Young children may withdraw and refuse to go to school. Adolescents may become irritable and engage in substance use or sexual promiscuity. Older adults may also be overlooked as they usually have physical complaints but could be related to or even causing their depression. Now, your priority intervention is to provide careful and unobtrusive observation for 24/7 on these patients because of the risk of suicide. Which question would be a priority when assessing for symptoms of major depression? B. You look really sad. Have you ever thought of harming yourself? Because you always need to be thinking about safety. So your nursing process diagnosis, you can see the examples on the slide. You have risk for suicide. Again, safety is always the highest priority. Chronic low self-esteem, imbalanced nutrition, constipation, disturbed sleep patterns, ineffective coping, and disabled family coping. You can also see Table 14.2 on page 252 for more examples. Outcomes, focus on the recovery model is healing, which focuses on the patient's strengths, developing mutual treatment goals, and determining the patient's personal needs as well as their values. Planning is based on the patient's phase of depression, their symptoms, and their patient goals. The nursing process continues, your implementation. There are 3 phases. The acute phase will last 6 to 12 weeks, and the goal is to reduce depressive symptoms and restore function. The continuation phase lasts 4 to 9 months, and the goal is to prevent relapse, and your maintenance phase is 1 year or more. The goal is to prevent further episodes of depression and maintain functioning. Counseling and communication. Communication may be difficult with a patient diagnosed with depression, as they may be withdrawn. Use simple and concrete words. Silence is not a bad thing because it allows time for the patient to respond. Listen for any covert messages and ask about suicide plans. You can see Table 14.3 and Table 14.4 on page 253 for further guidelines. So help teaching and promotion allows the patient to make choices and decisions in their care and exercise some form of personal control. Promotion of self-care activities, you can see Table 14.5 on page 256. For ideas how to help with those self-care activities. And then you have your teamwork and safety. All members of the team should be involved in the patient's care. Again, safety is priority and involves suicide precautions, rounding on the patient unobtrusively every 15 minutes or maybe even one-on-one observation. An evaluation is tailored to each patient's unique presentation. Basic self-care, thought processes, self-esteem, and social interactions. Pharmacotherapy. Remember that a combination of psychotherapy and antidepressant medication will be more effective than a single treatment method. There are a lot of things to consider when choosing an antidepressant for a patient. Things such as their symptoms, their side effects, ease of administration, history of a past response, and safety and medical considerations. If the patient is acutely suicidal, electroconvulsive therapy may be used since onset of improvement with medication typically takes 1 to 3 weeks. Trial and error experience, where one medication is tried for about 3 months, is often used. Also, according to the medications they're on, they may be on tyramine food restrictions for a lot of your antidepressants because it can cause a hypertensive crisis. I would be familiar with food examples for tyramines. So your antidepressants, we've already talked some about them in previous modules, but your SSRIs are considered a first-line treatment. It is best to take them in the morning to counter any type of insomnia, but they can take 4 to 6 weeks to work. So you need to educate the patient so they understand that they will not see immediate effects. With SSRIs, serotonin syndrome is a rare condition that is caused from the dosage being too high or maybe an interaction with other drugs. And you can see box 14.3 on page 259 to learn more about that. Your SNRIs can be considered, but SSRIs are usually tolerated better. Your TCAs, your tricyclics, are a second-line treatment due to adverse effects. An example adverse effect of your TCAs is a skin rash, because that can be indicative of Stevens-Johnson syndrome, which you will learn about in Med-Surg. And then your MAOIs are effective for unconditional depression, but remember that patients should avoid those foods high in tyramine. But with all antidepressants, educate the patient to report increased suicidal thoughts. So there are newer antidepressants out there. Which I'm not seeing right now, but I know they're in here. But newer antidepressants include serotonin antagonists and reuptake inhibitors, norepinephrine dopamine reuptake inhibitors, and non-adrenergic and specific serotonergic antidepressants. So a couple of the drugs specifically are your esketamine. That has been approved for treatment-resistant depression, and it's also used off-label for acute suicidality. We've already mentioned it before. It is a nasal spray that is used in conjunction with an oral antidepressant. It is a Schedule II drug. Next, you have brexanolone. It is the first FDA-approved medication for postpartum depression. Again, we've already mentioned it. It is only administered by a trained healthcare provider, because it is administered as an infusion over 60 hours. On pages, I think I skipped right over them. Table 14.6, here we go. Table 14.6 gives you a list of all medications used that are FDA approved for major depressive disorder. And then here are foods that can interact with those MAOIs, specifically those tyramine foods. So let's talk about special populations. In pregnant women, antidepressants cross the placenta, so the risk and benefits have to be weighed. Single medications should be used at the lowest doses, especially during the first trimester. In children and adolescents, the FDA issued black box warnings in 2004 for antidepressant use in children and adults because of that risk of suicidality. In older adults, polypharmacy is concerned, so they'll go into multiple drugstores. In older adults, SSRIs are a first-line treatment. So, Jeff was diagnosed with major depressive disorder. Which medication is the healthcare provider most likely to start him on? A, SSRIs, and you should know examples of those. So, other treatments for depression. You have integrated medicine, such as St. John's wort, which may increase the amount of serotonin, norepinephrine, and dopamine in the brain, but it is not regulated by the FDA, and as you learn in pharmacology, it interacts with so many different medications. But then you have your brain stimulation therapy, such as ECT, electroconvulsive therapy. It is approved for treating MDD or bipolar disorder in patients 13 years and older, but these patients will need careful monitoring for cardiac conditions, as well as a pre-procedure workup. That pre-procedure workup is going to include an ECG to identify any cardiac abnormalities or changes. They need a chest x-ray, and they will need labs. The patient will receive up to 6 to 12 treatments. Often after treatment, the patient will be confused and disoriented for several hours, and they may even have memory loss. It is important, if a patient is going to get ECT therapy, to make sure that they have given informed consent, unless they're receiving involuntary treatment, and you need to check vital signs prior to starting ECT. There is repetitive transcranial magnetic stimulation. This is a non-invasive use of magnetic pulses to stimulate focal areas of the cerebral cortex. It is used to treat mild treatment-resistant depression. There can be absolutely no metal in the procedure area, and those with seizures should be treated with low frequency. Treatment will be 5 days a week for 4 to 6 weeks. Following the procedure, the patient may experience pain on the scalp, headache, fatigue, and lightheadedness. Next is vagus nerve stimulation, which helps boost the level of neurotransmitters to improve mood. The FDA has approved this for treatment-resistant depression. A device is implanted into the chest wall with a thin wire that is threaded up to the vagus nerve that delivers a small pulse frequency for 30 seconds every 5 minutes for 24 hours a day. Common side effects include voice alteration and hoarseness. Page 2, so this is ECT. This is the repetitive, and then this is the vagus nerve stimulation. And then there is deep brain stimulation, which is an invasive procedure in which electrodes are implanted to stimulate certain areas of the brain. Other therapies could be light therapy, which is considered a first-line treatment for seasonal affective depression. It affects levels of melatonin, and the exposure should be at least 30 to 45 minutes a day. And then exercise. Exercise increases serotonin availability in the brain. Advanced practice interventions, you have your psychological therapy, so that's CBT, interpersonal therapy, time-limited focused psychotherapy, and behavioral therapy. And you also have group therapy. And just remember that psychotherapy is effective for treating depressive disorders because it is a long-term management. And finally, a nurse working on an acute mental health unit is admitting a client who has a major depressive disorder and comorbid anxiety disorder. Which of the following actions is the nurse's priority? A. Placing the client on one-to-one observation because safety is always your priority.